Good morning. Welcome back to Open Med School. In the last session, we have discussed about hyperkalemia and the ECG changes. Today, I'll be discussing about the ECG changes of hyperkalemia. Hyperkalemia when the serum potassium more than 5.5 is a medical emergency. And this leads on to predictable ECG changes. Recognition of these ECG changes are very important. This is what today I am going to discuss with you. So let us see what are the cardinal findings. 5 important findings are there in the ECG. First and foremost, it is the T waves. The T waves becomes peaked. Many normal adults can also have tall T, but they usually, if you superimpose on, you can see that the normal T has got a wide base. And the hyperkalemia, the T is sharp, the base is narrow, and it goes to a peak. But in a normal person, this is not like that. They will not reach that apex. So in hyperkalemia, the T appears like a pinched up voice. Something has been pinched up, and the base is narrow. Hope the number 1 point is clear. Second change that you get is the P wave becomes small, shallow, and it will disappear. So that is second finding. Third is the QRS. The normal QRS is narrow. When it is broad, when it is more than 2.5 small divisions, that is more than 0.1 second, we call it as a broad QRS, and the QRS become widened with hyperkalemia. And next is you get what is called a sine wave pattern. The ECG becomes something like a sine wave. And finally the fifth one, the patient gains in ventricular fibrillation. So these are the predictable changes of ECG, starting with the tall peaked T wave, disappearance of the P, widening of the QRS, sine wave pattern, and ventricular fibrillation. So this is what has been described here. So usually the changes are not there till it becomes 6 to 7. So usually the ECG findings are significantly present when the serum potassium is more than 7. More than 8.5, it usually lethal. Patient develops muscle paralysis, respiratory paralysis, or develops the life-threatening arrhythmias like ventricular fibrillation. And the early phases, that is 5.5, below that there may not be any changes at all. So progressively the changes occurring, starting with the tender T waves, loss of the P waves, widening of the QRS, and finally the sine wave pattern and ventricular fibrillation. Hope this point is clear to you. This is showing the ECG changes of hyperkalemia. You can see here in ECG the P waves are normal, but you can see that the T wave is appearing to be sharp, as if it is pinched upwards with a narrow base. Now you can see here the P waves have become flattened and the PR interval has been prolonged. So you can see the PR interval is prolonged and the P wave is flattened. In addition, you can see the tended T waves. Now we can see that the next stage the P wave has disappeared and progressively the changes are occurring. And finally this may end up in the sine wave pattern or ventricular fibrillation. Hope this point is clear to you. Now we just compare hyperkalemia. In hyperkalemia the changes are, it is the ST segment depression and appearance of the U wave, followed by the prominent P waves can sometimes occur with a prolonged PR interval. So that is the changes are different. In contrast, in the hyperkalemia, compared to hyperkalemia, here you see the tended T. Here you get the U waves. You can see again the peaked and the QRS is getting widened, ending in sine wave pattern, and finally it can end up in ventricular fibrillation. In experimental settings, hyperkalemia is associated with typical predictive findings, but in clinically, especially in chronic kidney disease, these findings are not seen in approximately 46% of patients. In experimental settings, the defined series of electrocardiographic abnormalities are shortening of QT interval, peaking of T waves, QRS prolongation, shortening of the PR interval, reduction of the amplitude of the P wave. There can be loss of sinoatrial conduction with the onset of the sine wave pattern, and ultimately asystole. There has been reports where even with a severe hyperkalemia, that is even concentration more than 9 milliequivalents, the cardiac manifestations were not seen. So ECG alone should not be taken for seeing whether the patient has got lethal hyperkalemia or not. Investigation and management of hyperkalemia will be discussed in next session.